This is a case presentation of a patient with a diagnosis of lumbar radiculopathy and utilizing the fascial manipulation method for treatment. It's a 56-year-old female who injured her back while lifting a table at work. She described pain as being at the level of 5 out of 10. Pain was worse with lifting, with bending, and with stooping. At this time, no imaging had been performed. You can see from the assessment chart that she had limitations with straight leg raise at 35 degrees, and also no changes in deep tendon reflexes. Most significantly, she had weakness in the ankle plantar flexors and described that her right leg feels shorter. You can see from the video that she has difficulty in maintaining a plantar flex position on the right, and the further she walks, the more difficult it is for her to maintain. The second visit following fascial manipulation treatment and the third visit following fascial manipulation treatment demonstrated increased strength and mobility. The fascial manipulation method has been developed over the past 35 years by Italian physical therapist Luigi Stecco. Beginning in 2010 was the first time the course was taught in the English language. This method takes into account the evolution of the fascial system, its role in muscle activity, force transmission, and also in motor control. It provides some unique perspective through taking a careful history, movement assessment, palpation verification, and this helps guide the clinician to narrow down precise localized areas of the fascia that need to be addressed with each individual patient. In recent years, this biomechanical model has been enhanced through extensive anatomical dissection, particularly in an uninvolved cadaver, as can be seen in the slide above, which demonstrates the myofascial continuity in the anterior region of the upper limb and helps to support the theory that the fascia has a role in proprioception and motor control. This model has also been enhanced through the histological study of the deep fascia of the limbs. In this slide, we show a variation of proprioceptors that are found within the deep fascia, as well as an interesting fact that the deep fascia is comprised of 3 separate layers, with each layer containing parallel running collagen fibers. When you place each of these layers on top of each other, then it gives the appearance of the undulating collagen fibers, which we expect in the deep fascia. With the patient presented here, even though she had significant straight leg raise limitations and motor weakness, which may indicate a nerve root lesion, we decided to take a look through the fascial manipulation method. In the myofascial manipulation method, the basic building blocks are constructed of myofascial units. Stecco has postulated that the deep fascia is a potentially active component in movement coordination and in peripheral motor control. Due to its innervation, the fascial component of each myofascial unit is a possible source of directional afference that can contribute to proprioception. Basically, the body is divided up into 14 myofascial units. Each myofascial unit includes the muscles, fascia, the joint that are crossed by the fascia and muscles, and the circulatory system, taking into regards all 3 spatial planes. In some portions of a muscle, the deep fascia slides freely over it, while in other parts it is tensioned directly through the myotendinous insertions that go from the muscle onto the deep fascia. Stecco speculated that the deep muscular fascia, each myofascial unit, there's a specific area called a center of coordination. He named this center of coordination as a focal point for vectoral forces that are produced by both the monoarticular and the biarticular muscle fibers for that unit during a precise movement. In other words, it's a culmination of the tensional forces on the fascia that are generated by both the agonist and the antagonist for a specific spatial movement. Stecco further observed that the gliding of the fascia over these points was often impeded, and he speculated that this could cause an incoordination of muscle fiber activation and an alteration in normal joint mobility. In this case, the patient presented with consistent alteration and decreased fascial gliding in the frontal plane for the pelvis, the knee, the ankle, and the foot. Initial treatment resulted in an increase in 15 degrees of straight leg raise, as well as a decrease in pain throughout the lower extremity, complaining of only pain in the posterior aspect of the right hip. Second treatment resulted in an increased straight leg raise to 75 degrees and a resultant 4-5 strength with manual muscle testing of the ankle plantar flexors. You can see from the video initially that the patient progressed over the 3 visits treating with the fascial manipulation method with
Okay.
a normalized straight leg raise of greater than 75 degrees, 4+5 strength in the ankle plantar flexors, and no pain in the lower extremity.